Thank you, and thank you all for joining us today. And I'm really excited to talk about our study. This is the first proper time we're actually sharing all the findings. And as Eleanor said, the study looked at the impact of minimum unit pricing on people experiencing homelessness, on street drinkers, and also we talked to service providers who work with this population. The study was led by Professor Rory Elliott and Professor Carol Emsley at Glasgow Caledonian. And I really want to mention here our third sector partners, Homeless Network Scotland, who were involved in the study from the beginning, and their peer researchers were instrumental in helping with our fieldwork. And just before I start, I just want to highlight the study is funded by the Chief Scientist Office, and we have no conflict of interest to declare. Today, I will talk about minimum unit pricing more generally and in Scotland, and I will spend most of the time talking about our findings, first from the perspectives of homeless and street drinkers, and then from the perspectives of the service providers. And as Eleanor said, there will be plenty of time for Q&A and discussion. Minimum unit pricing sets a minimum price per unit of alcohol below which no alcohol may be sold. And the aim of minimum unit pricing is to reduce alcohol consumption, particularly among hazardous and harmful drinkers, then leading to reduction in alcohol-related harm overall. The World Health Organization recommends the 3 best buys to address alcohol-related harm, and pricing is one of the 3 best buys. And this includes taxation, but also minimum unit pricing. And there are different benefits of minimum unit pricing. There is a lot of research showing that it can lead to reduced level of alcohol consumption and alcohol-related harm overall in the general population. But it might be particularly effective in reducing alcohol consumption and harms among heavy and harmful drinkers, particularly those with low income. And colleagues from University of Sheffield have done a lot of research in terms of modelling studies showing how minimum unit pricing can lead to reduced alcohol-related harm. And there was a study in Canada looking at how increases in minimum alcohol prices can also help reduce harm in people who have particularly low income. One way that minimum unit pricing works is because it targets the cheapest, strongest drinks. So thinking here about white cider or super strength lagers that are sold in big bottles, and they're usually over 7% ABV. And also thinking about own brand spirits. And these are the type of drinks that are consumed mostly by the heaviest drinkers, especially with those with limited income, because the drinks are strong in terms of alcohol content, but they're fairly cheap compared to other drinks on the market. SHAAP was the first organisation in Scotland to call for minimum unit pricing, and this was back in 2007 when they published a price policy and public health report. And it wasn't until 2018 when minimum unit pricing in Scotland was actually implemented, and it is set at 50p per unit. And just to give an example of this, what this means, so if you look at the top here, these are the prices before minimum unit pricing was introduced in 2018. And there were no changes in terms of pints of lager in pubs or wine sold at supermarkets, because these drinks were already being sold at higher than 50p per unit. Looking at the far right, at the big 3-litre bottles of strong cider, they used to be sold for £4.50. And after minimum unit pricing was introduced, the minimum a bottle of cider could be sold for is £11.25. So you could see a huge jump in price here. And vodka was also affected, not as significantly as cider, but you could see that there's about £4 increase in price for a standard 70cl bottle of vodka. Minimum unit pricing is one of the best evaluated policies in Scotland. The problem with with such policies is that it's really hard to evaluate them, because it's really hard to take into consideration all the different factors that can influence the policy. There has been a theory of change developed to explain how minimum unit pricing may result in a series of outcomes. And this is the theory of change model, and this is led by Public Health Scotland through the monitoring and evaluating Scotland's alcohol strategy programme. You can see here in the blue box that when minimum unit pricing is implemented, it can lead to reduced health and social harms through a series of linked outcomes. So once it's implemented, obviously retailers will need to comply with it. If compliance is high, no alcohol will be sold under 50p per unit, which will then lead to reduced purchasing of alcohol, which will then lead to reduced population consumption, and finally reduced health and social harms. And as a result of this, we also may see changes in product and marketing, but also changes in social norms and attitudes towards alcohol. Looking at the purple boxes at the bottom, there are other outcomes that may result from the changes above in the green boxes. So there could be an impact on the alcohol industry, displacement of spending, and potentially when people can't afford alcohol anymore, they might prioritize either necessities such as food and fuel, or they might prioritize alcohol. So this is what we mean by displacement. It could also result in substitution. So when people can't afford alcohol, they might start taking non-beverage alcohol or illicit drugs. And also, if people can't afford alcohol anymore, they might want to go into detox or need support in reducing drinking. So there would be an impact on demand for services. And at the very top, in the green box, it considers different external factors that might influence the impact of minimum unit pricing. This could be changes in benefit welfare, for example, where people might have more or less income. But also thinking more recently about COVID as well, because COVID affected the way services work and the way day-to-day life happens, it could be that interfered with the impact of minimum unit pricing. And I will highlight some of the studies that have already been published that try and explain some of these outcomes on the theory of change model. For example, impact on off-sales and small retailers. These studies found that minimum unit pricing was associated with a 3.5% reduction in off-trade alcohol sales per adult in the first year after implementation. And colleagues at University of Stirling found that cider experienced the most change in product range. So here, thinking about the big bottles of cider, where we saw a huge increase in price, after minimum unit pricing, there were decreases in the number of different cider products being sold. So this means retailers reduced or stopped stocking these products because people weren't really buying them. There's also another study looking at the impact of children and young people. And 40 talk to service providers who work with families where parents are drinking alcohol at harmful levels. And service providers suggested that when parents had a possible dependence on alcohol, minimum unit pricing alone might not be enough to address this, and people might need more support to address the reasons underpinning their drinking. And another study, which is probably closest related to ours, although the sample is different, looked at the impact of minimum unit pricing on dependent drinkers who were engaging with treatment services. And the authors found little evidence of either substitution to illicit, stolen, or non-beverage alcohol, and little evidence of increased use of other substances after minimum unit pricing was introduced. And by non-beverage alcohol here we mean things like mouthwash or hand sanitizer. The study also found that a minority of people who are dependent on alcohol may have reduced daily living expenditure due to spending more money on alcohol. And as I said earlier, this is something that is considered in the theory of change model, where displacing funding and displacing, like rebudgeting and spending more money on alcohol daily living expenditure is factored in. And there was also missed opportunities for services to raise awareness of minimum unit pricing and available support for people wishing to reduce drinking. There's no study so far that has looked at the way minimum unit pricing affects those that are at the margins of society, so the most marginalized groups, such as homeless and street drinkers. And these groups may be particularly susceptible to pricing interventions because the levels of alcohol-related harm and alcohol dependence among homeless individuals are higher compared to the rest of the population. And also, the volume and types of alcohol typically consumed are especially damaging to health. And for the purposes of our study, we define homeless individuals as those with experience of rough sleeping, temporary or insecure accommodation. And street drinkers are those who regularly drink outdoors in public places because they either don't have access to domestic spaces or they can't afford to drink in licensed premises. As I said, we don't actually know how minimum unit pricing or minimum pricing policies affect homeless drinkers. And to try and get an idea, we can look at more generally the way homeless people respond to changes in their finances. So what they do when they can't afford alcohol. And a study in Canada found that when alcohol-dependent individuals with experience of housing instability couldn't afford to buy alcohol, they talked about reducing alcohol consumption or they rebudgeted their funds. Similarly, looking at an intervention in England, whereby off licenses stopped selling super strength beers and ciders. And the homeless drinkers, the study found that homeless drinkers are likely to adopt substitution behaviors. So they could consume different drinks when they can't find the cider, or they might just start looking for places where they could still buy super strength ciders. The impact of minimum unit pricing on homeless and street drinkers hasn't been explored. And our study is the first study to do that. And it's a qualitative study, so looking at the impact of minimum unit pricing from the perspectives of homeless and street drinkers, but also from the perspectives of the support services that work with this population. And I want to highlight here that we had a stakeholder group and a steering group who were involved in the project from the very beginning and who advised at key stages. The stakeholder group was comprised of people from the third sector, people with lived experience, policy leads, and also academics. And again, I want to highlight here the important contribution from Homeless Network Scotland and the peer researchers who helped with the field work and helped us recruit the homeless and street drinkers. And the steering group provided advice on the academic, ethical, and policy implications of the research. So first I will focus on the experience of homeless and street drinkers, and then I will move on to talk about the service providers' experiences. We conducted qualitative interviews with 46 people in Glasgow, and there were 30 men and 16 women in our sample with an age range of 21 to 73 years. 18 of the participants in our sample are identified as street drinkers. So these are people who talked about drinking on the streets. And the majority of people lived in supported accommodation or a specialist. At the time of interview, they were in a specialist alcohol detox unit. We also measured people's relationship with alcohol, and we used the Audit C, which is a standard tool to do that. And you can see that the majority of people in our sample scored high enough to indicate possible dependence on alcohol. 9 of the participants talked about using drugs, and this is not something we asked participants about. It was just something they mentioned naturally in the interviews. Homeless and street drinker interviewees were aware of minimum unit pricing, although we interviewed them almost 2 years after, they still remember the price change. For example, this woman here says, it was very widely advertised and talked about in the media and shopkeepers. There were signs up saying the price was going to change in May 2018. Some of the participants were supportive of MUP, and this is primarily because they believed that strong ciders are particularly damaging to health. So this man here says that cider was killing people. And another participant said, the bottles of white lightning and stuff like that, they shouldn't be allowed to sell so cheaply, you know. I don't think you should be able to get drunk for £4, to be honest with you. Others had more concerns about minimum unit pricing, and they felt that minimum unit pricing in isolation would do nothing to address the social inequalities perceived to underline and exacerbate alcohol problems. And people told us about different reasons for their drinking, and they talked about trauma and the hardship of day-to-day life. And this participant here says, I think if we had just kind of a better society where, you know, what we have is distributed a bit more fairly, I think people wouldn't feel the need to self-medicate in general terms quite so much. So you can see here that participants had doubts about minimum unit pricing working in isolation without additional support. Reported impacts on the quantity and type of alcohol consumption were varied. Some of the homeless and street drinkers told us they reduced drinking, which is in line with the policy intentions. For example, the first quote here says, I couldn't afford to drink as much as I did. And another participant said that physically reducing your alcohol is one of the hardest things in the world to do on your own, so you need help. Thinking here about the theory of change, I mentioned in the beginning that there might be an impact on treatment services. You can see here that some people said that even if you want to reduce your drinking when you can't afford alcohol, you might need support from services to do that. Others experienced no impact on their drinking as a result of minimum unit pricing. And most of the time, this was because they were drinking drinks that weren't really affected by the price change. So thinking about wine, for example. And this man here says, it didn't influence my drinking because it's the same wine I was drinking 10 years ago. It wasn't a lot of difference in the price when the minimum pricing for a unit went up. Some of the participants told us that when they couldn't afford cider anymore, they switched away, and a lot of them moved on to vodka and other spirits. So the first quote here from a woman says, I went on to the vodka rather than getting cider because I was basically budgeting. But the next question here is, if people switched from cider to vodka, did that change how much they drink? And it was really hard to actually find that out from participants' accounts. And one person here says, I don't know if it affected the amount of alcohol I take, but it definitely affected what type of alcohol I was taking. So it definitely changed what people are drinking, but we don't know if that was more or less compared to what they drank before minimum unit pricing. Some of the homeless and street drinkers were concerned that switching away from cider and onto spirits has negative consequences for their health. And one participant said, vodka is too strong, it's a spirit. I'm just actually out of the hospital last Thursday. I burned all the lining in my belly and nearly died. So he felt that his poor physical health was a result of drinking vodka. As I said earlier, 9 of our participants talked about using drugs, and they did that before minimum unit pricing. And some of them shared that street drugs or street Valium in this occasion helped them not drink as much. So among people who are already using drugs, it seems that some of them use drugs just to top up when they couldn't afford alcohol anymore. And because it was so hard for participants to attribute any change in their behavior directly to minimum unit pricing, we asked them more generally about their strategies for getting alcohol when they can't afford it. A lot of people told us they would beg for more money just when they needed it or when they're desperate. And this was something that happened before minimum unit pricing as well. But one participant talked about how after minimum unit pricing happened, they had to beg more. So he said, it really affected me right at the time because I was like, and he's growling here, you're out begging for money, you get money, and you've got £2, and you think, yes, that's 2 cans. And then you remember, no, it's 1 can. But that just made me even more determined to go and get more money and to do everything I would to get the money to get booze. And some participants mentioned stealing as well, although it didn't seem to be common practice in our sample. And again, it was something that happened before minimum unit pricing as well. Like this non-street drinker here says, I've just walked in, stuck 2 bottles of wine in my jacket, walked right out the door when I've not had the money. I've never done it a lot, but I'd say it's more than once, especially if you've got a drink in you and you want another one and you haven't got the money, you just go fuck it and you just go in and you take it. And thinking about these possible concerns that people would stop buying essentials to prioritize alcohol, again, it was really hard to know whether this got worse after minimum unit pricing. For some people, it did. And people talked that they would just go without food, just as long as they had money for drink. And they would just say I wasn't eating that much because of my drinking. Total life was just drink. Borrowing and pooling resources seemed to be a widespread practice among homeless drinkers. It was something they talked about doing before minimum unit pricing. The first quote here says, it was like somebody got paid 1 week or this day and the next day. So it was all kind of helping each other. And another one says, I share my alcohol and when they've got, they share theirs. So this was just something that people did in order to manage their drinking until they get paid. And most of the time when they say they got paid, they mean when they had their welfare benefits. So brief summary of the key findings on homeless and street drinkers. Homeless and street drinker interviewees were generally aware of minimum unit pricing, but was accorded lower priority in their hierarchy of multiple concerns and other difficulties they faced on a day-to-day basis. Reported impacts on the quantity and type of alcohol consumed were varied. Some individuals reduced their drinking, some were unaffected, some switched drinks, and for some, the balance of alcohol vis-a-vis drugs consumed shifted towards the latter. Minimum unit pricing exacerbated an existing tendency for a minority of problem drinkers to beg or steal to obtain alcohol, or to prioritize acquisition of alcohol over necessities such as food when they ran out of money. So now we want to talk about the experiences and views of service providers and other professionals. We conducted qualitative interviews with 41 service providers and other professionals from across Scotland. And they worked in charities, NHS, police, Scottish Government, Public Health Scotland, and local authority housing and social work departments. So the first thing we talked to them about was about their expectations of minimum unit pricing before it was implemented. And a lot of them said that there were these talks and concerns about the potential of minimum unit pricing to have negative consequences for homeless and street drinkers. For example, this pharmacist says, so I was aware of it, I understand the reasoning behind it, but I was skeptical as to whether it was even going to work, just based on the fact that the population that I work with, people will beg, borrow, steal to get their drug of choice. So there were these concerns. The next question is, what did services do to prepare for these potential concerns? Some of them told us they received briefing notes and information materials, but most commonly they said there were just these discussions, are more people going to come into treatment? So service providers did talk about the potential impact of minimum unit pricing. Some of the services prepared more than others, and particularly third sector homelessness organizations, they seem to have done more to prepare for the potential impact of minimum unit pricing. So this team leader here said, so there was a kind of whole huge, how will this affect people? How are we going to support people if they're maybe suffering from DTs, if they're heavy drinkers and they're now having to withdraw? So there were kind of contingency plans discussed and put in place as to how we best support people. However, a lot of organizations told us they made no particular plans at all in preparation for minimum unit pricing. And this GP here said, we were certainly well aware of it and supportive of it, but I'm not sure I can't remember any particular specific preparations that were made in terms of thinking about consequences of the introduction of minimum unit pricing. We also talked to service providers about the impact of minimum unit pricing on their services. And the first quote here echoes what most of them said, that they didn't see much impact. This team leader said, I think there was a lot of talk about it. I don't think we're really seeing the impact. And despite initial concerns about homeless people prioritizing alcohol or food and other necessities, this was not seen as common practice. Some service providers reported an increase in the use of food banks and drop-in centers that provided free lunches, but this was more pronounced after the onset of the COVID-19 pandemic. And this links back to the theory of change model, that there are these external factors that happen that might interfere with the effectiveness of minimum unit pricing. And especially here, it's really hard to disentangle whether participants use food banks as a result of COVID or minimum unit pricing. We talked to service providers about what they thought the impact of minimum unit pricing was on homeless and street drinkers. And some of them told us they noticed reduced drinking in their patients or clients. For example, the psychiatrist says, I can remember one lady, she springs to mind, who said, look, I can't do this anymore. I have an alcohol problem. I can't get my alcohol supply anymore. Please, can I have detox through the service? So this echoes what some of the homeless people said, that they wanted to reduce their drinking. Service providers also told us that they noticed people switching away from the strong ciders, and some of them saw this as a positive switch. For example, this third sector homelessness organization manager said, a lot of them drink cider. I mean, the strongest cider is obviously gone up enormously in price, so it's probably been beneficial for their health. A lot of them have gone from that really poisonous, almost strong cider, this frosty jack type stuff. They've gone down to Strongbow, which is, it's a 5% regular apple-based cider. So I would say it's improved their health in many ways. Others had more concerns, and a few of the service providers working directly with homeless people reported a range of negative health consequences for drinkers, including falls and head injuries. And in extreme cases, they felt it contributed to people's death. And there was this concern among some service providers that when people switched away from cider and started to drink vodka, in the short term, they were struggling to calibrate how much vodka to drink to get the same level of intoxication they used to when they were drinking cider. And this is why they experienced these negative consequences. Other consequences, service providers in our sample made limited observations of increased use of illicit drugs and non-beverage alcohol. There were a couple of occasions where people said they thought there was an increased use of hand sanitizer, but that was mentioned in relation to a very small population of homeless drinkers who have no access to health benefits and welfare benefits. So there were isolated instances of this. And begging or stealing by homeless and street drinkers following minimum unit pricing were not observed by the service providers in our sample. And finally, a lot of the service providers talked about the importance of provision of support for people to reduce or stop their drinking. And this policymaker here said, I think what's not fully understood is what needs to go alongside that type of approach with certain populations, including homelessness, is that you need to give people options to be able to reduce their alcohol consumption if they want. And a lot of the service providers told us that homeless and street drinkers have a lot of complex needs. So they have the difficulties they experience on a day-to-day basis, which can lead to physical problems, to mental health problems. And a lot of them have experienced trauma in the past. And all of these needs need to be addressed. And the social worker here said, I'm keen to stress, specifically for my client group, that minimum unit pricing has been a bad thing, because there are people that are alcohol dependent, they can't access any services or resources to address that because they're excluded by being who they are. And this team leader here, I'll elaborate a little bit on this idea that people are excluded from services by being who they are. And they said, everything about services is very much, you must fit these criteria to get in. And that's, our guys won't always fit that because, again, because of lifestyle, trauma and abuse, there's drugs, there's alcohol, there is abuse, there is, you name it. So it's trying to figure out what comes first. So again, this highlights here the need for services to work together to address all of these complex needs. And minimum unit pricing is just one aspect of this. So just to sum up the findings on service providers' data, minimum unit pricing had negligible, if any, discernible impact on services that work with homeless and street drinkers. Most service provider interviewees reported feeling insufficiently prepared prior to its implementation, and only a few had supported staff to initiate conversation with service users about the policy's potential implications. And participants highlighted the imperative of ensuring that suitably holistic and psychologically informed services, which are equipped to meet the intersecting needs of this population, are more readily available if alcohol-related harm among homeless and street drinkers is to be reduced. So finally, our overall conclusions are that minimum unit pricing worked as intended for some homeless and street drinkers, others were unaffected, and a minority experienced unintended consequences. Minimum unit pricing had negligible or no impact on services supporting homeless and street drinkers, and opportunities to exploit potential benefits were missed. Policymakers need to devise plans to mitigate the unintended impacts and promote the potential benefits of minimum unit pricing for homeless and street drinkers. And our final project report is available on the CSO website. And thank you very much.